My name is Janet Varnes, and I'm Executive Director of the Illinois CancerCare Foundation. And I want to thank you so much for joining us this afternoon for our first Cancer Survivor Expo. We're so pleased that you took the time to come out this afternoon. Just a few things before we get started with our formal remarks this afternoon. I just wanted to introduce, I know a number of you have already met some of our staff that are here representing a number of the Illinois Cancer Care departments, but I just wanted to introduce them formally to you. From pharmacy, we have, where's Tim? Oh, Tim's in the back. Tim. Palliative care, where's Tammy? Tammy's in the back. And I know from the Bloomington office, Sarah and Laura should be joining us shortly. Of course, we have Drs. Kumar Gomez with us from research, Caitlin in the back. And again, part of the reason for this expo was to bring information about services to you. So they are here for you to answer any questions that you have. Even after the formal remarks, they'll be available to, again, answer any questions you might have before you leave this afternoon. But again, thank you for joining us. We are pleased to be able to offer this program to you. It was made possible through a grant that our foundation received a few years ago from the Amgen company. And part of that grant was to really communicate the importance of clinical trials and clinical trial participation in helping find new treatments and cures for many types of cancers. And another part of that grant was to be able to provide outreach to rural areas just outside of the Peoria region. So this is one of 6 programs that we're taking throughout Central Illinois to benefit our patient population. Just a few words about the foundation. I think each one of you have at your place a little brochure that looks like this. So I would encourage you at some point to take a look at that. But the funds raised by our foundation really meet a couple of missions. First of all is supporting clinical research. We know that important scientific discoveries are made every day through clinical research that again advance treatments, improve treatments, and hopefully provide cures for many types of cancers. And the funds that are made to us by a variety of constituents and companies and organizations really support that effort in meeting the shortfall between what we receive from the National Cancer Institute and what it really actually costs to provide that service to our patients. So that's a main priority of our foundation. We also know that the best way that we can provide support for patients is through prevention of cancer. And we support a number of screening programs to identify hereditary cancer, really with special emphasis on families that are at risk for hereditary breast cancer and for hereditary colorectal cancer. And again, this is an opportunity for us to provide families with relief from uncertainty and to help them make informed decisions about their health care. We also have launched a new program in genetic tumor sequencing. And again, this support helps financially disadvantaged patients who may be candidates for targeted therapies, which again can be offered here close at home, and then hopefully help them fight cancer with greater precision and with potentially fewer side effects. And then above the kind of clinical support that we provide, we also fund a number of patient support programs. Again, we have a Trust and Hope program whereby we provide compassionate support to cancer patients and their families during the holiday times, Thanksgiving and Christmas. And again, we have a cadre of volunteers that travel all over Central Illinois to provide the service to our patients and their families. So that's a program that's very near and dear to our hearts. And then again, our support is intended for patients that are served at all of our clinics, all 12 of our clinics, and 100% of the dollars raised stay locally in Central Illinois to benefit patients. Before I introduce our speakers today, each of you have a little a note card here, and there's a purpose for that note card. As you're listening to Dr. Kumar and Nancy give their presentations this afternoon, we'd like you to feel free to jot down any questions that you might have for them. And then when we're done with the formal programs, Leslie and Lauren's in the back, Leslie's at the registration desk, they're from the foundation office. They'll come around and collect those, and then we'll get to as many of those questions as we can before our time is up. We want you to really look at it as an opportunity to get your questions or inquiries answered while the experts are here. And so don't be bashful about writing down questions. Most of you in this room probably know Dr. Kumar, so his reputation precedes himself. I probably don't need to go through a lot with him, but I just wanted to make some formal remarks about his medical background. He joined Illinois CancerCare in 2007, and he completed his residency at the State University of New York Health Sciences Center. He completed his oncology and hematology fellowship at the Montefiore Medical Center at Albert Einstein Cancer Center in New York City. He is board certified in internal medicine, medical oncology, and hematology, and he is the current president-elect of the Illinois Medical Oncology Society, a tenure that will stretch from 2016 to 2018. And again, that's a large oncology society in the state of Illinois. Also with us this afternoon is Nancy Donini. Nancy is an oncology certified registered nurse, and she's been at Illinois CancerCare for 9 years. She serves as the genetics nurse coordinator, and she works very closely with all of our oncologists, hematologists in helping genetics patients understand and manage their risks for developing cancer. Nancy is very passionate about her work with our patients, and she's really tireless in piecing together the genetic puzzle for them to help them determine the best course of treatment and follow-up for them and their family members. She is a graduate of the intensive course in cancer risk assessment that was presented through the City of Hope Division of Clinical Cancer Genetics in Duarte, California. And then along with other participants from around the world, she participated in a very elite form-up program, which is really recognized as the premier source of comprehensive practice-focused genetics training in the world. So she has a lot of experience and does really a great job in working with all of our physicians and with our patients. So with that, I'm going to turn it over to Dr. Kumar first, and then we'll follow with Nancy, and then we'll take your questions.
I'd like to thank the foundation for inviting me for this meeting. It's a great honor for me. I'd like to keep my presentation short, so we have more time for questions and answers later on. I'm going to talk about future directions of treatments in oncology. We all know that cancers are no longer treated it's similar with treatments that we used to utilize, let's say 10, 20, 30 years ago. A lot has changed in many different cancers. The treatments have gotten a lot more specialized. And most of it has occurred because of better understanding of the biology of cancer. We know the genetic structure of these cells are more than we did before. And we know a lot more about how these cells grow And that has helped researchers evolve new treatments. So I'm going to tell you, to begin with, I'm going to tell you two stories. The first story is highlighted over here. So this is the front page of Time from May 28, 2001 edition. And this talks about this magical drug called Gleevec. So the story behind Gleevec is the following. Chronic myeloid leukemia is seen in about 5 to 10,000 patients per year in the United States at this point. This was a dreadful disease. Before these medications came about, almost 90% of patients died in less than 5 years, and it was miserable for these patients. They had to undergo intensive chemotherapy and very harsh treatments, including transplant from utilizing cells from other people. And despite that, it didn't really work. So, and then this medication came along called Gleevec. So the story, like anything else, if you want to understand what's going to happen in future, you first have to understand what happened in the past. So let's go back. 1950 is when this story started. There were two guys, a professor called Hungerford and his graduate student, a guy called Noble, who went on to become a very leading pathologist down the road. These guys were interested in leukemias, so they were trying to understand the biology of leukemia. They looked at the chromosomes in these patients, and they could not find any pattern until they discovered only 5 patients, who had one particular type of chromosomal problem. And they studied it more and more, and it turned out that those 5 patients really had what we call chronic myeloid leukemia, this one, CML. They discovered the chromosome. It was discovered in the city of Philadelphia. They called it Philadelphia chromosome. So Philadelphia chromosome equals CML. All right. This information stayed in medical books for about 20 to 30 years. This is how we made a diagnosis. A couple years down the road, few more papers were published where the scientists discovered that when this change occurs, the so-called Philadelphia chromosome, these cells are actually forming a new protein, which is called BCR-ABL. So the next bright idea was, can we make another drug which will go and bind this new protein and neutralize this effect and eradicate the disease? And that's exactly what they did. They came up with this drug, which was called Gleevec. Imatinib is the medical name. And once the drug came about, remember, in past, almost 90% of patients died at less than 5 years. Nowadays, I'd say at least 95 to 99% of patients are alive and doing extremely well. They have no problems. They're going about their lives as if there's nothing wrong with them. A major change. And the last 10 years, many new medications have come about. To name a few, there's a drug called dasatinib, nilotinib, bosutinib, ponatinib. I can go on. It's a long list of names. So this was a major change. This represented the first so-called future of oncology drug. In which patients were not getting chemotherapies, but they were getting very specific treatments. Second story. All right. This gentleman here, I can point out. This gentleman here is the guy that I'm going to talk about next. So his name is, or was, he died a few years ago, Moses Judah Folkman, F-O-L-K-M-A-N, Folkman. He was born in 1933 in Cleveland, Ohio. He was the son of a rabbi, and quite a famous one, I understand. His dad and mom both wanted Judah to become a rabbi and serve in the temple, but Judah had other ideas. I think he decided to become a doctor. He said to his dad, I'm going to be a doctor. And I think he decided to not be a rabbi because his dad asked him to be a rabbi. So his dad did not give up. His dad actually said, Judah, you can be a doctor, but can you also be a rabbi at the same time? Well, it didn't work out. But Judah Folkman went on to become a brilliant surgeon. He landed at the end of his training at Children's Hospital in Boston, and we've been told that Judah Folkman decided to get into research and stop clinical practice because it said that he was more interested in lab than in seeing patients. I think what really happened is that he got tired of weekend calls or being available or being woken up in the middle of the night. But I'm glad he did go into research and went into the lab. So he had some very interesting ideas. So one of his ideas was, he said, in order for cancer cells to grow, cancer cells need food. Cells need oxygen, and these cells need food. How do they get this stuff? They get it from blood supply, right? So he said, okay, these cancer cells must be feeding themselves somehow. And that was their line of work. This team of researchers was, I understand, his original team from Children's Hospital. And these guys spent a lot of time investigating and studying just this process. So this group first published their findings in 1971. It's a major breakthrough. They discovered a compound, they gave it to a couple of rats, and the tumors completely vanished. They published it in big scientific journals, and everybody in the scientific community conveniently ignored it. But that's common. That's what happens in life, right? Whenever you come with a new or bright idea, the first reaction always is ignore him. What does he know? He's just new kid in the block types. But these guys persisted. It is said that Judah Folkman said to his team that I knew there was only one thing in my favor, which is that I knew I was right and everybody else was wrong. Nonetheless, they persisted, and finally in 1980s, and now we start to evolve into the future of oncology. This drug company, Genentech, also made a similar discovery. In fact, they discovered the proteins that Folkman's team had been investigating for a long time. And the next step was Genentech, in collaboration with a lot of other scientists, made a protein which blocked the formation of blood vessels into these cancer cells. And that protein is nowadays called Avastin. It's a medication which is given to patients who have lung cancer, patients who have ovarian cancers, patients who have colon cancer, and this medication made a dramatic effect in the survival of our patients. So, this story that I just mentioned, that I just said to you, has been repeated time and time and time again. I'll go through this briefly again to make sure that we have more time to talk. So, for example, breast cancer, initially in the olden days, they looked at receptors, estrogen receptor, progesterone receptor, anti-estrogen medication was given to these patients. But then, a few years ago, a discovery was made about a protein that was found on the surface of these cells called HER2/neu, and then several medications were made that would block that protein on top of the cell, and when these medications were given with chemotherapy, or even without chemotherapy in some cases, these medications made a huge difference in the survival of our patients. Same story goes on in lung cancer. It's not enough to say you have lung cancer. We need to know nowadays what kind of lung cancer is it. In terms of what is called non-small cell lung cancer, is it what we call adenocarcinoma or is it non-adenocarcinoma? And there are specific types of treatments. But then, about 15 to 20 years ago, a group out of Boston and Einstein that I trained, Sloan Kettering and MD Anderson, they came up with this gene called EGFR. It turns out that if a person has this gene, then we can give them tablets. Tarceva, afatinib, and until recently we had what is called Iressa. If you give these patients tablets, these pills, they have a much better response than chemotherapy. They live longer, they live better. Well, the story changed again. If a person has lung cancer and has this mutation called ALK, called ALK gene, you can give them another tablet called crizotinib, and it works better than chemotherapy or any other older treatment. And if crizotinib fails, you've got a new medication for them called ceritinib, which was just approved by FDA 3 or 4 weeks ago. This is an unending story. It goes on and on and on. You can pick a cancer and you can come up with newer treatments. So for example, melanoma. If a person has melanoma, we look for what is called mutation in BRAF gene. If they have this mutation, they can get another tablet called Zelboraf, or a combination of 2 medications called Tafinlar and Mekinist. If they do not have the mutation, there is another type of treatment available called Yervoy, which is an IV medication. In colon cancer, we look for a gene in these patients called KRAS, K-R-A-S. If the gene is functioning normally, then these 2 medications, Erbitux and Vectibix, work extremely well. Same story in kidney cancer. We look for newer kinds of treatments that I mentioned here. In patients who have lymphoma, if they have CD20 positive lymphoma, they can get rituximab. Rituximab has increased the survival of our patient by, it's doubled their survival. In the olden days, without chemotherapy versus chemotherapy plus rituximab, these patients live much longer. It makes the treatments more effective. And there's a newer version of rituximab that I mentioned here. It's too long, I can't say the name. Maybe one of the pharmacy guys can tell us. CD30 is another medication, another molecule. If it's positive, they get brentuximab, which is an antibody. Prostate cancer, newer types of medications come about. So this story has been repeated on and on. And this story, these medications or diseases that are mentioned, is a very brief summary. So what's the bottom line? This is a graph, a cartoon of the survival trends in the United States. This was published in 2014, this year, by National Cancer Institute. And you can see that across the board, our patients are living longer and longer. The death rates are decreasing steadily in these patients. So it's happening in men and women. Now, some of this improvement is because lifestyles have changed. Less people are smoking. There's less hepatitis B, hepatitis C. We have better diagnostic tools. But some of this is definitely because of these better, newer treatments. And we need to keep this process going. And this has all occurred because of research, and it takes a lot of time and effort. So, a famous saying from Einstein, I'm going to quote Einstein, and in parentheses are my words. Einstein said, life is like a bicycle. To keep your balance, you must keep moving. So I'm going to change that. I'm going to say science or oncology, cancer treatments are like a modern bicycle. For us to make balance, for us to keep balance, for us to make progress, we have to keep moving. Thank you.
Dr. Kumar, that was a really good lead-in to what I'm going to say, because as we've made so many advances in cancer care because of the biology of the tumor, the genetics of the tumor, so to speak, the genetics of every cell in our body and the genetics of the tumor are starting to come together, and it's kind of amazing what's going on right now. So I'm going to talk about screening in cancer prevention, diagnosis, and treatment, because if we can keep you from getting cancer in the first place, then our goals are met. That is the ultimate, is to keep people people from getting cancer. So who should be screened? Published studies show that 37% of all breast cancer patients should be screened for a genetic defect. 100% of all ovarian cancer patients. So if you have ovarian cancer, you need to talk to your oncologist about genetic testing. And up to 24% of all colorectal cancers should be screened for a genetic defect. And that is in the person, not necessarily in the tumor. A little bit of background. Only 5 to 10% that we know of cancers can be attributed to a hereditary cancer predisposition syndrome. But identifying those patients benefits both the patient, obviously, and then their at-risk relatives. Oncology patients benefit by receiving personalized short-term and long-term care. So short-term care, if you're a newly diagnosed breast cancer patient, what kind of surgery should you have? Well, being tested for a BRCA mutation, for Leukemia syndrome, for an ATM mutation, all those can factor into a decision you're going to make about what kind of surgery. Are you going to have a lumpectomy and radiation? Well, no, if you have Leukemia syndrome, no radiation or ATM. Are you going to have a simple mastectomy? Or if you have a BRCA mutation, maybe you're going to have a bilateral mastectomy because you know there's a big risk of the cancer, of the second cancer occurring in your other breast. More and more, just as Dr. Kumar talked about, treatments can be affected by whether you are a BRCA carrier or not. People with BRCA mutations and breast cancer often, and ovarian cancer as well, often respond to a class of drugs called PARP inhibitors. So as we study these diseases more and more, and the genetics of the person as well as the tumor, we're going to find that treatment decisions kind of can come from what we're finding. Long term, an example, a breast cancer patient who knows they have a BRCA mutation is also at risk for ovarian cancer, so they take care of the breast cancer, but now what? You know, you don't want to turn up 10 years later with ovarian cancer, or 5 years later with a different kind of tumor in your other breast. So if you know that you have a genetic mutation, you're going to base the decisions about your long-term care and survivorship on the knowledge that you gain from genetic testing. So survivorship plans can be tailored to incorporate surveillance and prevention for increased risk of second malignancies. There's lots of guidelines out there. There's no hard and fast rules, and what one person finds is the right decision for how to treat their cancer based on the fact that they have a genetic mutation isn't necessarily what another person has to do or needs to do. But you should at least understand your risks and make informed decisions based on the knowledge that you've gained from being tested. So an example, this is when people come to the genetics clinic at Illinois CancerCare, we try to go through their family history as thoroughly as we can. Send you a little email link and have you fill out an online pedigree. It asks you questions and kind of formulates something like this. And then we go over your history when you get there, because this is the most important piece of the puzzle. So this is a pedigree of a family who has a BRCA mutation. And as you can see, you have a lot of younger people affected with breast cancer and ovarian cancer at young ages. You have prostate cancer and melanoma. So this is kind of if somebody with any kind of genetic training looked at this pedigree, they would say, well, I hope that family's been tested for BRCA. So this is what you might find. When you start looking at your family history, if you start to come up with something like this, then that's what your oncologist is going to say, we better get you tested. This is an example of a family history of Lynch syndrome. Lynch syndrome was HNPCC, hereditary non-polyposis colorectal cancer, but the oncologist who spent his entire life trying to prove that you could inherit a propensity to develop colorectal cancer, Dr. Henry Lynch, he used to get thrown out of conferences for even saying, like Dr. Kumar said, he was the new kid on the block who just thought that you could inherit colorectal cancer, and they would throw him out of conferences. Well, I had the honor of being at a conference where he spoke, I think it was his last talk ever. And he got a standing ovation from a room full of his peers, and I thought, you know, everybody should live long enough to see that their idea got accepted, and then actually the medical community embraced it. It was kind of a moving day. But anyways, in Lynch syndrome, you see, again, younger people, although depending on the gene, you could not get colorectal cancer until your 60s or 70s. There's different genes in Lynch syndrome, so this is more of a classic case. So you see colorectal cancer in the 40s and 50s. You see women with endometrial cancer or uterine cancer. Those all go, and then there's a ureter cancer, those, an occasional breast, although the jury's kind of out on that. But that's a typical Lynch syndrome family. So again, you know, delving into your family history, if you start coming up with relatives that fit this kind of a mold, then someone, and preferably someone with cancer in the family, should be tested. So your family history is the key to identifying individuals at risk for both primary and secondary cancers, and to identify the individuals most likely to benefit from genetic counseling testing. Typically, the best person to be tested in a family is the person affected by cancer, because if there is a genetic mutation in the family, they're the most likely to have it. It's not always possible. If, say, you're a 45-year-old with breast cancer and your mom died of breast cancer and your aunt died of ovarian cancer, well, obviously they cannot be tested. Well, actually, if you have breast cancer at 45, you should be tested. Say you're a 45-year-old unaffected person, but you've had a lot of family members die of breast and ovarian cancer at a young age, your insurance company might allow you to be tested because no one else could. The goals of cancer family history: provide enough information to provide a preliminary determination of risk and familial predisposition. So when you sit down with your oncologist, it's kind of hard at that initial visit because it's hard enough to be told you have cancer. And then the oncologist has to help you understand your disease, help you understand what kind of treatment you're going to get. And that is a lot for a patient to swallow on the first or second visit. But the nice thing about oncology and oncologists is patients develop a bond with their doctor. It's different than, you only go to your medical doctor when you have to, but you actually develop a relationship with your oncologist. So after you settle into your treatment, or you even are on the other side of treatment, you still follow up with your oncologist. They still do tests. They still make sure your cancer's not coming back. So that's the time, a lot of times, when you can go back and say, you know, at Thanksgiving we were all talking and Aunt Mary had this, and I found out my cousin had another cancer. Those are things to go ahead and tell your oncologist about, because that's changing your risk. You know, all of a sudden you now have a family history, so maybe genetic testing is appropriate. Your management plan is going to change depending on what your family history is. And then as more information about the family becomes available, whether to test you or not might change, and then how to manage you going forward might change. So your risk for developing cancer and then your perception of risk can change over time. Like I said, if you're newly diagnosed with breast cancer and you're 54 years old and you go and you tell your oncologist, well, I don't know where this came from because nobody in my family has cancer. The oncologist's first thought is not going to be genetic testing. But then, like I said, as you develop this relationship and you talk to your oncologist more and more, and you say, you know, I found out about this relative and that relative, that's going to change your risk, and that's going to make your oncologist think maybe genetic testing is in order. And then knowledge of risk for carrying a genetic mutation and the perception can change as knowledge of family history changes and the perception of the risk changes with it. So how are we doing? We're not doing very well. We're doing better at identifying people with cancer who should be tested, but we're not doing very well with unaffected family members. And the only way to stop people from getting cancer who have a genetic family history, or to at least catch it where you can cure it with surgery, is to identify unaffected people with genetic mutations. And in 2012, Drohan et al. Did a study, and they estimated that only less than or equal to 5% of all unaffected carriers of BRCA1 and 2 are being identified. and only 1% of unaffected carriers of Lynch syndrome. So we definitely have room for improvement. So when you're wondering, like, what exactly would qualify somebody to want to come in for a risk evaluation or for genetic testing? So for hereditary breast and ovarian cancer, age of diagnosis is big. If you're diagnosed under the age of 50, you should start thinking. It's triple negative. I know a lot of breast cancer patients understand, and Dr. Kumar kind of touched on, if it's estrogen receptor negative, progesterone receptor negative, and that protein Dr. Kumar talked about, HER2 negative, and you're under 60 years old, you should think about genetic testing. If you have a personal history of ovarian cancer, any male with breast cancer, if you have 2 different breast cancers, that's another red flag. Anyone who is Jewish, Ashkenazi Jews, and most of the Jews in the United States are Ashkenazi, they have actually a much higher rate of genetic mutations, and they have 3 specific, we're called founder mutations. So Ashkenazi Jews should definitely have that conversation with their doctor. Lynch syndrome, if you're diagnosed with colon cancer or uterine cancer under the age of 50, more and more, and this is something it's kind of my thing lately, we'd like to see every single colorectal tumor, like somebody's diagnosed with colon cancer, they have to do pathology on what they take out of you to determine that it is cancer. While they're doing that, they can also do a very simple test to test for mismatch repair genes, and if they find a defect, it's a tip-off that you could have Lynch syndrome. It should be part of all the pathologies for colon cancer, and in some states it is, but we're not quite there yet. There's certain things about the tumor that are a tip-off. If it's mucinous, if it has signet ring cells, infiltrating tumor lymphocytes, if it's on the right side of the colon, those are all tip-offs that it might be Lynch syndrome. If you have 2 or more Lynch syndrome cancers at any age, and that would be somebody with both colon cancer and uterine cancer, or colon cancer and cancer of the ureter or bladder, things like that. These are all reasons to have that talk with your oncologist or be referred for a genetic counselor. So what can you do? What can everybody in this room do to make sure that your family stays healthy? Because if you're affected by cancer or not, you don't want to be, and you don't want your family members to. So what can you do? You can learn as much as possible about your family history. That is so important. And if I've not learned anything doing this, is people do not know nearly enough about their family history. You need to share the information that you find out with your oncologist or your family physician. You need to update your history when you learn new information and share it with your oncologist or your primary care physician. Genetic counseling and testing is warranted if your risk is high enough. We have risk models. We can go through your family history. We can plug them into different models. We can come up with actual numbers, and those numbers can convince your insurance company that you should be tested. Medicare is pretty straightforward. If you meet the guidelines, Medicare pays for your test 100%. But you do have to have cancer in order to be tested have Medicare pay for your testing. So if we test you and we discover a genetic mutation, then you need to share that information with your family, because your family members are the ones that should be tested for what we found in you, and then you can come up with a plan to stay healthy. Because if you know, say you're 43 years old and you know that your sister just got diagnosed with breast cancer, and she was tested and she has a BRCA mutation, and then you go get tested, and then you find out that you have the same mutation. Well, now we can come up with a plan to either keep you from getting breast and ovarian cancer, or at least catch it at a stage where we can remove it surgically. There's lots and lots of things we can do, but we have to know you're at risk. That's it.
Thank you, Nancy. Now's the time we're ready to take your questions. So if Warren and Leslie would maybe help kind of collect the questions you have. And Nancy, you want to come back up, and we'll have you. And while they're doing that, though, I do want to just reinforce that, as Nancy mentioned, if you have a family member, and this is really specific to the colorectal, the Lynch syndrome, and the breast cancer, if it's determined you have family members that should be tested, Nancy is great about working with insurance companies to get those testings paid for. But if for some reason you have a family member who doesn't have insurance, or they're unemployed or underemployed and finances are a barrier to that testing, our foundation has monies available to pay for that testing for your loved one and for those patients. So please keep that in mind, and feel free to share that with others that you know, because this is really a high priority for us. Nancy, you want to come up and kind of field the questions? I can pick on you, Jennifer. You're used to me picking on them. I'll turn the lights up a little bit too. And then Doctors Kumar and Gomez, when they come back, the three of them will work to answer your questions. So again, feel free if you haven't turned in a card and a question comes up, just raise your hand. We'll come around and get your card.
Dr. Kumar, some of these are more doctor questions. I can move a couple. One of these, we'll split this one. Is there any pushback from insurance companies for covering preventive measures for cancer? Well, Obamacare is pushing for it. I think it's going to get a little better. We're still in like a transition period, but I think it should get better, not worse.
Okay. Are there any tests that could be performed during routine physicals to diagnose cancer in the earliest stage? Okay. So this is a very difficult question to answer. I wish we had that one blood test that we all could do and tell our patients what you have. But the answer is no. I mean, there's no good answer. Because the problem is, cancer is not one disease. There are hundreds of types of cancers. It's a bit like, the way I look at this question is, you could translate this question into, is there a test that can be done to find out if I have an infectious disease, for example? We can, because there are hundreds of types of bacteria and viruses. So there is no one test. Now we do have some early diagnosis tests, for example, mammograms, though there is some controversy involved in that too. But it is a test which is available. Colonoscopies in men, PSAs, but majority of the cancers, I would say, besides the ones that I talked about, are detected because of some symptoms that patients have. Now there is a lot of controversy about CAT scans and lung cancer. There is very large research that was done on about 50,000 patients, in which it showed that if patients who had smoked a lot, if they did a CAT scan, we can detect lung cancer earlier. But just last week, a report came out from United States Preventative Health. This is on one big, giant federal organization in which they essentially said they are not going to pay for it. So, it's difficult. Yes, there are some tests, but most patients probably will not be able to have a very good test. Now, what you should do is you should do what is called age-appropriate cancer screening, which is colonoscopies, mammograms, PSAs, in women, female exams, and things like that. I think that's probably the best we can do at this point. What is the treatment for esophageal cancer? And Pat, please pitch in. I have my partner Patrick Gomez, also Dr. Gomez here too. We both see a lot of these cancers too. Esophageal cancer is a cancer of the food pipe. Typically depends on the stage of the cancer. If it's early stage, these patients can have operations. Sometimes these patients need radiation therapy or chemotherapy to shrink it, and then they have operations. Patrick, your thoughts?
Well, when you look at cancer, you try to stage it, so if it's an early stage versus if it's stage 4, which is metastatic. So in particular for esophageal, if it's a localized cancer, we typically do chemotherapy and radiation first and then do a resection if it's going to be resected. However, if it looks like it's disseminated and gone somewhere else, then it's predominantly chemotherapy. So it's important when we do the evaluation for esophageal is we try to see if it's localized or spread. And it's usually a combination of chemo, radiation, and surgery called trimodality therapy, or it's chemotherapy that's spread.
So the next question is, I hear both good and bad about mammograms. What about this? I think you don't need a doctor to answer this question, you need a policymaker to answer this question. I like Nancy and Patrick, but also and help out. So it's definitely controversial. We do know that it's been the standard for a long time for women to have mammograms. There is a lot of battle, almost it appears, that has been going on about at what age it should be started and at what age it should be stopped. There were some studies that have been done in other countries, particularly in Canada in the last 2 months. A study came out that showed that in Canada, mammograms are not found to be helpful in thousands of patients. I think the most people at this point agree that mammograms should be done at least possibly starting at age 50, maybe sooner. At this point, nobody is recommended against mammograms in the US, so I think it should be continued. The problem is there are a lot of people in whom mammograms overcall a lot, and there's a lot of testing that is done. And some, at least there are a lot of people, experts, who are saying that maybe a lot of these cancers that are being detected are not that harmful, and maybe it's not that useful, but it's a controversial topic. Please, Richard.
Well, I do know OSF has started that, is it tomosynthesis? I think it's called. It's another way of looking at the tissue, and they say it's not a lot more radiation, and they're catching a lot more cancers in dense breast tissue, and they say they're getting more or less false positives. So I think they're making progress.
And so just comments on the mammogram. Again, prevention is our goal. It's not 100%. Breasts that are dense can hide a mass. If you feel a mass, even if the mammogram is normal, that needs to be evaluated. As we refine our radiology techniques and combining with ultrasound, maybe we'll be continuing to improve on it. And really, when you look at prevention, you're looking, these screening tests, we're looking for overall survival. So when you're really looking at some of these tests, they're very expensive when you look at the whole aggregate, and if they don't really show a survival, then it's not a really good screening test. But we do know that it does improve survival in some studies, and so that's why it's an active, it's not a perfect screening test. For women that have the BRCA test that's positive, their risk is even higher, and sometimes MRIs are recommended. But again, these are case by case, insurance costs, everything. And so right now, we recommend that you get mammograms starting at age 40. Some in Canada maybe not that early, 50, but we recommend it right now at age 40, and then depending on the special circumstances of whether you've got the genetic predisposition to express, then other things may be taken into consideration.
This question: is there more risk for family members for a family member with several different types of cancer in the family? My answer to that is it depends on what those types of cancer are. It also depends on, are they on both sides of the family? Are they on mom's side, on dad's side? That matters. Like if you tell me that my dad died of lung cancer, his brother died of esophageal cancer, another brother died of bladder cancer, And then you tell us that they all smoked heavily and drank a lot, and then the first thought is not going to be that it was a genetic problem. So it depends. Then, like when we talked about the slides, you look for constellations of cancers that fit a mold, like the Lynch cancers. Like, did they have it? Is there endometrial? Is there colon? Was there bladder cancer? Things that fit a certain syndrome.
I think that pretty much sums up the answer. So there's one question here: how can I find out when new drugs are FDA approved? So there are many different sources. The best source, I would say, probably FDA. I agree. And the American Society of Clinical Oncology, which is an organization of all the cancer doctors in the United States, and actually internationally at this point, has a website called cancer.net. It's a very unbiased website, because that's always very important to get unbiased opinions in our field. And the other good site, at least that I use a lot, is National Cancer Institute. There's a lot of resources that it's taxpayer funded, and there's a lot of information available. I'd say.
Yeah. And just to add that, you may notice that sometimes we give therapies that are not FDA approved, and that doesn't mean that it's not standard of care. So if you happen to be getting a drug, or you put it in there and it's not, saying it's approved, there's a lot that goes into standard of care in terms of how to treat somebody. So we use NCCN guidelines, National Comprehensive Care Network. You can get that online also. .org that also helps you in terms of some recommendations and guidelines. But just to let you know that not everything is FDA approved that we do, but it's based on trials and data that's been published. And so it's not always going to correlate with that.
So the next question is, how will the new healthcare system, ACA, affect treatments and research? So again, I think you need a policy maker, you're not a doctor. But I'll tell you research part, because who's here from research? All right, see our research lady sitting in front, in the back, excuse me. We do know that last year, in the last at least 2 years, the funding of National Cancer Institute's budget for research has been slashed. I think they said $2 billion less money was given. So I think, at least from a research standpoint, this is definitely affecting the growth of and the search for new treatments, at least in the United States. The U.S. has been the leader in the world for all these fancy treatments that people talk about. They all started right here, and the rest of the world also benefits from it. But it's a process that is, to a large extent, is funded by has been funded by the national through the National Cancer Institute. There is definitely some degree of funding that comes from pharmaceutical companies, but I think they are not. I think the bulk of the work is still being done by national organizations. And for example, in our practice, there is a big shortfall every year in the research program, and we thank foundation folks and donors who've been supporting the research program that at least we conduct in our practice through all these sites that we participate in. So I think research is definitely being affected negatively, and I think this trend will continue. I don't see any improvement in the near future, at least. As far as treatments are concerned, again, it's sort of a negative trend. Thoughts?
Well, you're probably sitting there going, well, it's all nice. We come up with these new drugs. We have research saying that these are going to work. And then we say, okay, we want you to take this drug, and you have to, you find your insurance isn't going to pay for it, or you have $5,000 deductible or something like that. And that's a big problem, because we're seeing it more and more. And I really want to emphasize how much our pharmacy with Illinois CancerCare does in trying to research and get copay assistance and finding the money to help pay for these drugs. We have been really successful in doing that. And Tim, he's back there in our pharmacy. We run through everyone we have. We run through our pharmacy to see what we can do. And if you got a big copay, if you can't make it, we look for all the resources that are out there. There are a lot of drug companies, organizations that give this copay assistance, but we do everything we can to provide you with the drug that we can give you, because we're interested in giving you the best care, and we've been very good at that. In terms of what's going to happen in the future, it's going to be a struggle. You just have to realize that insurance companies are putting more and more emphasis on the patient paying for some of these drugs, and they're very expensive when they come to market. So that is something that we always we're always watching. We're always trying our best to provide everybody with the availability of the drug. But we've got to hand it to our pharmacy. We really have a lot of resources to try to help patients. So if you, when you're asked to well, let's just put it this way, we do our best. So if you have any questions, or you want, with your own drugs, or you're worried about that, be sure that we've looked into that for you if you don't feel we have.
So another question which kind of relates to what was the previous question. The question is there a pushback from insurance companies for covering preventative measures for cancer? I think we sort of touched on that a little bit. Preventative measures for cancer usually involve, number one, doing an early screening test. As of now, from what I understand, most of our patients have been able to get the common screening tests, commonly available screening tests. There are certain medications that have been used, for example, in certain types of condition. For example, certain forms of pre-malignant condition of breast cancer, there are certain medications available. I've taken care of 1 or 2 patients. It's not been a problem, but that may be because most of these treatments are not really expensive. But I think, as Patrick mentioned earlier, the trend is in general sort of somewhat negative. It's not that optimistic, but I'm not giving up hope. I think we need to.
But as far as the screening, I think the standard ones, the mammograms, the colonoscopies, I mean, those are all mostly going to be, if you have standard insurance or Medicare, those are all going to be, the patient's going to be able to do that. I think the ones that are a little more expensive, like the screening for the CT scans for the chest, is probably not going to happen for Medicare. But what other people think, well, I like a whole body PET scan, I like a lot of tumor markers. There's people come in and go, well, and this has to do with people that do have that predisposition. So you have Lynch, you have the BRCA, you're worried, so you want that scan to make sure you don't have prostate cancer, you want to have a whole body PET, and that's where things get a little bit difficult because of the insurance companies do regulate that, they look at that, we're constantly have to get approvals for that, and so that's probably not going to happen, and that's where you're going to get the pushback right now. But again, you need more data, more research. What is the best screening tool? Because these are expensive and they have to show a survival advantage. And even though we have shown that with the CT of the chest, we're still getting the pushback on that.
I think we finished up with our written question. Are there any questions that we can answer? Please feel free to speak up.
We're going to be hanging around here too, so if you want to do it privately, come on up and we'll be glad to answer any questions.
Yes, ma'am.
I have a question kind of on a follow-up for the research that you're talking about, funding and stuff. So I think probably all of us in the room get mailings all the time asking us to donate to this cancer and that cancer funding. Is there a particular one that you should search out for that you know will be going to research? Because sometimes you send to those thinking it's going to research and it's administrative stuff it goes to or whatever.
Well, again, there are lots of organizations, not only locally but nationally, that are cancer support organizations. I think one of the things that you might want to think about doing, again, especially if you're computer savvy, is I think there's a website called Charity Watch. They will tell you, they do a lot of research, especially on the larger cancer organizations, about what their overhead is. How much are they spending on it, on administration? How much is really going towards research? So you can certainly, at least on more of the larger national organizations, you can find that information out, and that will help you make an informed decision about where you want to put your philanthropic dollars. In terms of our foundation, our monies are all local. We don't have to send a percentage of our dollars to a national organization like a number of other organizations have to do. We're very fortunate in that the practice is very supportive and provides for a lot of our overhead, so we don't use that. We don't use donor dollars to pay for salaries and that sort of thing. So again, I think it's a decision you have to make about where you would like your philanthropic dollars to be, whether you would like to support, in terms of research, basic research, bench science research, which we do not do. First, we support clinical cancer research. And then again, just trying to find as much information as you can to make an informed decision about where you'd like to put your dollars. Hopefully that helps.
Mm-hmm.
Does that help you?
I just want to add one more statement to that.
It's very important for all of us to at least let our policymakers and the politicians to support research, because there is a great deal of I should say complete lack of interest in this field. I mean, they all seem so occupied with the present that nobody's worried about the future. And it is important. The point where we've reached so far, we've reached it because of what happened, I just showed you, 1950s. So if you want to be, we want this process to be continued, we want it to be supported. So if you have any influence with any of the policymakers, please give them a call, tell them to support research.
Yes, Elsa.
I don't know if any of you are AARP readers, but I just got our publication yesterday, and there's a major article on the cost and how the pharmaceutical companies why they're not, the research is not moving as fast as it could. And my question was, how can we as individuals, and yes, our policymakers in the government, and but anyway, read that article, and if AARP has anything to do with it, I think we need to support them and have those kind of organizations who have some clout and some muscle to get behind these, or I will not call them that, but these individuals who are in it for their own, for their own money profit, and letting the rest of it just go over the hill. So that's a question that I have.
I would just make a clarification, actually, 2 points. One to the point about our research and specific types of cancers. We have trials in most cancers, and will accept gifts for many of the major cancer groups, breast and colorectal and lung and the blood disorders and things, where we sometimes will not accept gifts if they're for like a very, very specific rare type of cancer, in which we may only have a trial every couple of years or something. We will usually decline accepting those gifts. And I think the second point, in terms of what our foundation supports, we do not support industry trials. We support trials through our CCOP, which is the funding through the NCI. So we're not supporting trials where pharmaceutical companies are profiting from that. Anything else? Well, yeah, we'll stick around for anyone that has any questions. And again, just a couple of things before we close today. I think each one of you have an evaluation form at your table. If you would be so kind to